No, I'm good. Yes. It's great. How are you? Good. I know I sent you an email. I think you were out of the office when I was out there chatting. Here. After travel like crazy. Yeah. I know I wanted to connect with you after the last meeting. How much they learned and what a good news feeling it was. So we can connect sometime. I was sitting in town. So travels was good. You know, like delayed flight delays or anything. Chicago wasn't so crowded yesterday. I was missing my boat here and we got there almost 2 hours early because of the yeah. All right, hi guys. We'll go ahead and get started. My name is Staci Czyzewski, and today I'm going to focus on our medication assistance program. So really a pharmacy focus, where what we've kind of heard already today is more focused around financial navigation as a whole. This is really going to be pharmacy centric. So some of the objectives we're going to look at today are an effective evaluation of our current state. So process mapping, networking, really kind of seeing where you are right now and where you want to go. Next will be successful planning. So communication, automation, really big players in planning of your program and where you want to be. Finally, we'll have the obstacles, which is really going to be a primary focus of this. Definitely facing a lot of obstacles as you look to centralize your assistance program and expand your services, and really, kind of recommendations on developing that successful program. So just a quick background. Again, my name is Staci Czyzewski. I'm the Enterprise Pharmacy Business Manager for WVU Health System. We are a 18 facility health system. We're also joining an additional 4 hospitals within our system here in the next year, with a total bed count of over 3,000 across the system. We just recently began our journey. We're only 3 years old, starting in March of 2019, with very few resources. So we started with just a pharmacy technician, myself as manager, and our director as we implemented our program. We are spread across West Virginia for the most part. We also have facilities in Ohio, Maryland, and Pennsylvania. So with that, we're looking at a lot of different rules with the different states. We also have 340B and non-340B facilities within our system. And within those 340B and non-340B, both dish facilities and critical access facilities. In addition to that, we also have a consolidated services center in the works where we hope to place our medication assistance program. So why pharmacy? Really the biggest thing we wanted to look at in centralizing the medication assistance program to pharmacy was to have one person or one team really focused on taking care of the medication aspect of assistance. Originally, there was an external company that we had hired, RxWorks, that charged us a percentage of the assistance that they were able to find in order to help our patients. It was great. We didn't have the resources. They were able to help our patients, but we really felt that we would be able to capture more if we were able to do that hands-on and in person. With RxWorks, we were only able to help about 13 patients a year, and we were only looking at 2 specific medications in the oncology world. Since then, as we've grown and we've taken things in within pharmacy specifically, we've been able to increase that over the last few years to 240 patients that we're assisting, and we're looking at about 50 different medications across the board, not just in oncology, but also neurology, and within our Heart and Vascular Institute. We work with the manufacturer free drug. We also work with financial counselors. So the financial counselors within our organization are still handling copay assistance and charity care. We really felt that they had kind of perfected this. They're doing a great job with it. We didn't want to step on any toes right off the get-go. So really it was a collaborated work to get together with them and make sure that it was our communication. So making sure that as they find somebody that needs copay assistance, we're getting them to them. And if it's somebody that needs free drug, the financial counselors are also working very closely with us to refer those patients to us. We've also worked with providers. The providers and their staff, specifically nursing, was handling a lot of the patient inquiries for assistance initially. What we found was that was taking a lot of their hands-on nursing, more clinical time away from them. So if they were able to refer those patients to us, we could handle starting the applications and getting those patients the assistance they needed, rather than them spending their time doing that paperwork, following up with the organizations or the payers to get the assistance they may need. The other piece of that, with multiple people handling, was that patients were receiving communications from multiple people across the organization. We oftentimes in the beginning found patients were getting frustrated because they didn't know who they were supposed to be talking to, because they had their nurse calling them, they had a financial counselor calling them. There were just so many hands in that pot and so many people reaching out to that patient that they didn't know who to go to for the help that they needed. So really wanted to get that under one umbrella and have one number for them to call. And then finally, the delivery and billing coordination. This was a major factor in bringing medication assistance into pharmacy, because what was happening, medication assistance was getting applied for by social workers, financial counselors, nursing staff, and getting facilitated with the organization. And they were using their office address and their office contact for those applications. So when it was time for the patient's treatment and it was a medication that was going to be given in our infusion center, it wasn't coming to our infusion center. It was either going to the doctor's office, it was going straight to the patient. The nurse or the social worker was getting the phone call to set up delivery, so then they were having to take time away to do that. With pulling everything under one umbrella and us handling the applications, pharmacy was the contact person. The delivery address was pharmacy. All the medication was coming directly to us. We could coordinate getting it there in time for the patient's treatment. And we could also on the back end make sure that the patient wasn't getting charged for. So one of the main things that you have to guarantee when you apply for these medication assistance programs is that you're not going to charge the patient for that drug. If we didn't know it was coming in, since pharmacy handles the medication billing, we didn't know to not charge if that charge ended up coming through. So on the back end, we're making sure there wasn't a human error where that did get charged for, since we know that it's coming in. So how did we do it? So getting things started, one thing that I can't say enough of if you're wanting to start something new, especially around this, is talking to other facilities. Everyone here wants to help the patients, and we're in various stages of our process and where we want to go. So use this opportunity to meet with folks while you're here to talk about what they've done, how they're doing it. I know right now with COVID, it's hard to go on physical site visits, but we do have the opportunity now to do virtual visits. So we've done a lot of phone calls with different organizations across the country. It really helps expand your resources with the virtual option. So we've talked to people as far away as Wisconsin and as close as Maryland, because we've been able to do that virtually. So kind of see what they've done, how they've done it, obstacles they've overcome. If you find an organization that has the setup similar to what you're envisioning for your facility, ask them if they're open to a site visit. Now that COVID is starting to slow down a little bit, a lot of places are open to that, and it really helps to see things hands-on versus just hearing about it. Right. So internal discovery meetings and process mapping. So once you're ready to get things going, you really need to know where you're at now. So if you already have a lot of different departments handling different aspects of this, you want to make sure what their workflows are in addition to yours and how you're really going to incorporate those together. So from our side of things, we had financial counselors doing the copay assistance and the charity care. As far as medication assistance, it was really all over the board: nurses, financial counselors, social workers, some pharmacy technicians, some pharmacists, depending on the clinics. So figuring out what they're doing now and how you can integrate that and streamline it best for the patient. You want to get to know who your key players are as well, because you want to build that relationship with them off of the get-go, because a lot of people are territorial about the work that they're doing. You know, they're doing it, they feel they're doing it best, and not to say that they aren't. But there's always ways, I feel, to improve efficiencies and really make things better. And then determine your resources. So as I said just a little bit ago, we started very small. So this is just kind of a little picture of our org chart off the get-go. Under my director, it was just myself as our manager. I was also managing at the time our 340B program, our revenue cycle program within pharmacy, and our finances, in addition to trying to develop a patient access services team. We were able to get one technician under that team to start this, and she wasn't even fully patient access focused. She was also doing finances and a little bit of 340B at times too, so that we could kind of prove that proof of concept and an ROI to gain additional resources. So I found this quote that really struck home from Theodore Roosevelt of "Do what you can with what you have where you are." So don't try to overshoot what you're able to do. You know, it's really hard to get FTEs. You'll probably hear that through a lot of presentations today. So you really need to evaluate what you have and see what you can do with it. So in the planning phase, we're going to process map again. So we had to explain to the C-suite and our upper management what we wanted to do and why we wanted to do it. Once we did that, we had to, and we got the green light, we needed to determine what the new process was going to look like. So we have our process flows from all the different parties that are joining forces and making this happen, but how do we make that one process flow? So this is just a small snippet of what our process flow looked like, just from the beginning part, and really show how things get routed to our patient access team. So we kind of started with the provider placing the order, how it gets through our authorization team and either approved or denied. And then you can see that when a denial is upheld, and also if there's a high copay or high deductible, but again, this is just a snippet. We utilize Epic at our organization, and these items then get sent to our patient assistance work queue. So we have multiple work queues that we've developed within Epic. We have one for a patient who either doesn't have insurance or is outright denied, and those patients get referred to a work queue there where we look specifically for free drug for that patient. We also have another work queue for high deductibles and high copays so that we can look for copay assistance in that regard. We do work very closely once we get items in those work queues as well with the financial counselor I mentioned earlier that helps with the copay assistance and charity care. So our patient assistance technicians and financial counselors work very, very closely together, almost like they're one team, even though they fall under different umbrellas. And that has been really key to helping the most patients that we can. Automation. So as I mentioned, our clinical software is Epic. and we've utilized these work queues to route referrals to patients. We also have a patient assistance solution that we use, Med Data Services, currently. It houses all of the applications that are out there for medication assistance programs. And once we add a patient in there, we're able to auto-populate their information as we apply for programs. We are looking at different automation currently as well. MedData, what we currently utilize it for, and I believe it has other pathways and opportunities as well. But what we use it for is solely the application process. Because we also have revenue cycle and finances under our team, and we're looking into moving into prior authorizations as well, we're looking at other opportunities where we can roll that all into one software. And then finally, identifying a pilot location. So I know Mike mentioned earlier, if any of you guys were here for his presentation, really identifying one pilot area. You don't want to take on too much all at once. You want to make sure you can iron out your process, make sure things are working correctly, and again, show that ROI so that you can get the resources you need to expand the program once you're able to perfect it. If you try to take on too much all at once, you're not going to be as successful as if you kind of pace yourself and identify those key areas. So we started with our infusion center. We have a fairly large infusion center at our academic medical center within our system, and that's where we started things. After that, we were able to expand to other infusion centers within the system because we were getting a lot of referrals from our clinics and providers to some of our smaller facilities that were maybe closer to home, especially with being such a rural area in West Virginia. So we expanded to those other infusion centers as well. And then after that, we expanded to our Heart and Vascular Institute to help with those patients. Some of the obstacles that we had to overcome, I did mention the interdepartmental relationships. Again, people are going to be territorial. They've done this for years. They know what they're doing. Not that they don't, but there's always, again, ways to improve efficiencies. So the understanding of their hesitation and that they care about their patients, and that's really what they want to make sure of, is that that patient isn't going to fall through the cracks or get missed, and that you're going to take just as good a care of their patients as they did. So explain to them how much you care about that patient's needs as well. Explain to them the process that you have outlined. We had one particular clinic that we went back and forth with. They did not want to hand this over to us. They wanted to continue to do things. And we probably had 4 or 5 calls with them over the course of 2 months, outlining exactly what our process looked like, trying to get them to understand how much we cared about their patients as well, and that we were going to take care of them, and taking on different divisions of that clinic at a time to get them comfortable with us taking that on. Service expansion. You're going to need resources to expand. And again, that's one of the hardest things to do. So making sure you have that ROI, getting your name out there. We have a newsletter within our organization that our president puts out. So we focus a story around our medication patient assistance program within that newsletter. And once we did that, he was very excited about it. Him being excited about it made the other clinics and areas excited about it as well. And instead of pulling back and saying, no, we want to continue to handle that, they were contacting us and asking us to take it on for their patients. And we had to slow them down and say, hold on, we've got to get those extra resources before we can do so. So getting your name out there is a double-edged sword. It gets them excited and gets them to want to use you, but you've also got to make sure you have the FTs to do so. And then developing new process flows. So that initial process flow that you outline isn't cookie cutter, one size fits all. Clinics are different, specialty areas are different. You may have to go through different workflows for different clinic types or the types of medication that you're doing. So initially, we did do infusion medications, and then we tapped into medications from our Heart and Vascular Institute that the patient's going to be taken at home. So a completely different workflow. So developing both of those to where the providers, nursing, whomever was going to refer a patient to us could all go to the same platform to refer that patient to us, but on our end, it was separate workflows that we understood and that we could divide up amongst our team. So we implemented Sherwell is the program that we use. It's a ticketing system where the provider, nurse, whomever realizes the patient needs assistance can go in. They can choose either a home or discharge medication or an infusion or clinic administered medication. And same platform, they just pick one or the other, and they provide us with the patient's information, and it gets referred to the appropriate team member to work on that. It's also nice because it helps track our metrics around the tickets that we have coming in, the patients we're assisting. I can watch productivity of my team members because they are hybrid right now because of COVID. So they're not fully remote, although I know a lot of these types of teams are. We've opted for a hybrid method so that they do have some time on site also. So it helps me monitor that productivity when they're not on site and I can't physically see them. And then again, that obstacle to overcome is becoming popular. So when you get your name out there and you're doing a good job, everybody's going to want you to help them. So just knowing kind of your breaking point and when you need to say, you're next on our list, but we need to go to the board and get this approval so that we can expand. Would really appreciate your support as we talk to them and talk through that. And then I just wanted to share our journey. So as I said, we started in March of 2019. We started with basically a half of an FTE since we were using our technician to help with financial and 340B items as well. And we started with our infusion center at our largest medical site, sorry. So we did use that FTE to initiate that service and then began our expansion as we went through the years. So once we showed our proof of concept in 2019, we were able to transition that technician to a full FTE so that she was solely dedicated to patient assistance. In 2021, back to 2020, at the end of 2020 was when we put that excerpt in our system newsletter about the program. And that helped us in 2021 gain an additional FTE so that we could expand those services to the clinics. And that's when we started providing to our HVI clinics. We fully expected that we would be able to expand that service to the HVI clinic and then other clinics throughout the year. But that volume was so large that we haven't been able to expand our services to any other clinics. Just in our HVI clinic alone, we service over 200 patients a year with our program with just one technician doing all of that. And that includes all of the re-enrollments as well. And then for this year, we did gain an additional FTE so that we could further expand our services. And what we're trying to do with that is really be more proactive in identifying patients. So if we're not getting referrals from the clinics or from our referral process within Epic, because, human error, patients could fall through the crack. We are running reports at the end of each month around self-pay patients or patients that we're seeing with a high patient responsibility. And we have an analyst that's going in and identifying if there are any programs available to that patient and contacting them. Hopefully we can find a replacement program and get their previous treatments taken care of. But even if we can't do that, if we can get them set up going forward, then we've at least helped them there. And then we're also working very closely with our denial services team. So our denial services team at our facility is focused on all denials. So they're looking at procedures, they're looking at devices, and they're looking at medications. So we wanted to have a pharmacy focus on the medication aspect of those denials so that we could be more proactive and really be able to see that maybe something was denied because of a lack of authorization, and we see that that patient has a treatment coming up in a week or two, and that authorization still isn't on file. We can then go in and attempt to get that authorization for them and get it taken care of before their next treatment so that then we don't get another denial for that lack of authorization. A specific example of that, we had a patient recently where the authorization was obtained under the pharmacy benefit versus the medical benefit. But the team who got the authorization did not call to get the medication ordered from the specialty pharmacy prior to treatment. So we had to treat the patient with our medication and then got denied. we had no idea that it was authorized under the pharmacy benefit when the patient came in. So we treated that patient twice, and the medication that they received was very expensive, and they got a bill for about $100,000 because it was denied by their insurance. So we were able to go back and make things right. But that was prior to us starting these denial services, and really what led us to do that, because we didn't want another patient to get a bill like that unexpected, and we wanted to be able to make sure that we were able to take care of them and get that taken care of. If we did, we ended up writing it off, but if we had caught that after the first one, it would have been a much smaller write-off for us. So another reason why we're trying to be more proactive in that regard. Our metrics, not quite as large as Mike's were that he showed. His were really nice. He has a software program that he's utilizing. This is something that we just put together on our own. Another reason why we're hoping to find a software program to help us with this. But we're tracking the doses that we're able to provide to patients, the costs that we're able to save, and the patients that we're able to assist. So this is just Q2 of 2022 across our organization. We break it down by our locations, and then again, the cost saved, doses provided, and patients assisted. We show this to our CFOs every quarter, as well as our CPO, so that they know kind of what we're doing and the value that we're bringing to the organization, in hopes that we'll gain additional FTEs. So technicians don't cost a lot of money every year. And if they're able to save with 3 technicians in just one quarter, 1.7 million, it blows my mind that it's so hard for us to get additional FTEs. But that's just the way the health system works. So we continue to throw that out there for them to see and show that value, because money talks to the C-suite, and hopefully able to gain additional resources down the road.
Can I ask, are
Yeah.
these drug replacements, copay assistance, or
so the top chart is for the infusion and clinic administered medication. So it's a combination of replacement drug, free drug. That's it. Replacement drug and free drug. And the discharge medications on the bottom are copay assistance and free drug for at-home medications that the patients are receiving.
Yeah, pharmacy cost or patient cost?
So that's where it's kind of hard too, and where we really want a software to be able to split that out. So the cost saved, we go with what the AWP is for the cost of the drug. You can really look at it 2 ways. It can be the cost to the organization. If we would have procured that medication and treated the patient and not charged them, that's what we would have paid. You can also look at it that it could potentially fall to the patient. They could get that bill and be held responsible. And if they don't raise the red flag to us and we don't know that they got that EOB, then they may end up paying that. Or the other piece of it too that we haven't been able to track is the quality aspect. How many of these patients, if they couldn't get this medication, would choose not to get treatment at all? So we want to find a way to factor that in there as well, but we just haven't yet. And I really think that will speak volumes to the C-suite as well, in helping us get FTEs of, this patient wouldn't have received care, and we're able to offer a better value of life by doing this. So recent expansion of services. We are looking to continue to expand our services and see where we can help more patients. So white bagging resolution, I use that term loosely and just assume everyone knows what white bagging is, but just a quick summary of it. So white bagging is basically having a specialty pharmacy send in the medication for a patient versus utilizing our own specialty pharmacy or going under the medical buy-and bill. So we are trying to limit the white bagging that is occurring within our facility. It's been very difficult, but we do push back with insurances and try to get them to allow us to bill under the medical benefit, or to allow our specialty pharmacy to cover those medications. The reason for this is really more so patient care. When something's being white bagged in, like I mentioned earlier, you run the risk of the product not getting ordered by the specialty pharmacy, coming in, us treating the patient, and then getting a denial, and getting that EOB saying they're responsible, or us ending up writing something off in those regards. Proactive patient monitoring, I mentioned a little bit ago, taking a look at those reports, making sure that we are looking at patients that we might be able to help that were not referred to us through our normal channels. Denial resolution, again, looking at those denials that are specific to a lack of authorization or even medical necessity as well, to see if maybe we can change a therapy or if we can get a prior authorization before the next treatment. And then medical benefit authorizations. So we've recently expanded to one of our critical access facilities that our centralized authorization services team was not handling medical authorizations for. And we started doing that under our umbrella within pharmacy because they were having a lot of denials or medications that were being given before prior authorization was obtained. So it's a very small volume since it's one of our critical access facilities. So we felt that that would be a good opportunity for us to take that on, figure out the best process flow, and then see what other facilities we may be able to help assist with in that regard as well. And it also ties into that referral piece too. So if we're handling the authorization, we get that denial or we see that they have a high copay, we can instantly start working on that assistance application for them instead of having that lag or passing back and forth between multiple teams. And then just a what's next for us. So we are expanding our services to the remaining infusion centers within our system. We have 4 facilities I mentioned joining us next year. Of those 4, I believe 2 of them have large infusion centers. So that's going to be something that we'll need to take on and determine the resources either they already have or that we'll need to obtain in order to do so. We would like to expand further to our clinics. Again, we thought that we would be able to handle more than just our HVI clinic with that one resource, and we haven't been able to, so we'd like to really be able to assist other facilities as well. Copay assistance. So we do work very well with the financial counselor that handles the copay assistance. A lot of times if we get something first and it should be copay assistance, we'll try to find the program to help them with the copay assistance piece because we do just have one financial counselor for our large infusion center. So we try to help her the best we can and say, hey, we were able to find the program. We know that you need to do the coordination with billing and everything for this, but here's all the information that you need. So a better collaboration of those services and possibly pooling under one umbrella or at least a dotted line to where they have an even better process flow together. Medication authorizations, as I mentioned, we've started the medical benefit authorizations at one of our small facilities. Would like to expand that. And then we're also looking at pharmacy benefit expansion. We have a specialty pharmacy that handles pharmacy benefit authorizations for medications being filled by them, but we would also like to have somebody assist when we do have to refer to an outside specialty pharmacy because there's no other option. Onboarding multiple new facilities and our centralized services center that we are planning. So for our centralized services center, we're going to do pharmacy warehousing, specialty and mail order pharmacy, which will have a lot of authorization and assistance needs through there. And then we're also going to have a leg of that centralized service center be medication access services so that we can pull everything that I talked about today and everything that we want to do into one facility under one board so that we have a better opportunity for speaking to our ROI and requesting those additional FTEs rather than having to go to all of the CFOs across our entire system. So that's a big hurdle right now with being a system. We're not just talking to one CFO, we're talking to 20. So we have to convince all of them to support our service. So moving to the centralized service center is key to us being able to go to 1 or 2 people to get that approval versus 20. And that's all I have for you guys. So I do have my email listed there, and I wanted to save time for questions. So any questions or comments that you guys have?
You talked about 340B. How does that affect your assistance program?
That's a good question. 340B hasn't impacted us too much. Our infusion center is solely 340B. But if we're getting the product, we're getting it free, so it doesn't impact the program. So we haven't had any major hurdles there thus far. Not to say it won't happen or it hasn't been brought to our attention yet. But so far, we haven't experienced any problems with that.
Thank you.
Your copay assistance
Yeah.
process.
Mhm.
I have several questions. I have
Okay.
this. One of them, it would be the billing process.
Mhm.
So when I go into different settings, there's usually lots of different processes. People
Mhm.
do it differently. In your setting, who bills the copay assistance programs and why?
So within our system, our copay assistants, our financial counselor, takes care of inputting all of the information, and then she coordinates directly with a billing team, and they go in and apply the appropriate copay assistance whenever the patient's bill is ready to be submitted to the insurance. So prior to.
So your billing office is submitting the claim to the copay assistance
Yes.
program.
Yes.
In your setting, especially in your infusion clinic, is every patient informed of copay assistance, or is it the squeaky wheel?
I would like to hope that they are, but that's a perfect world. So we do have a lot of social workers in our infusion center that really care about our patients, and I really feel like they're doing the best that they can to communicate that to all patients. But I feel like in any environment, the squeaky wheel is always the one that gets it. So I would like to think that they are, but I can't guarantee it, especially because our staff is the one that's on the front line. They're not seeing those patients as they come in, so they're not there to educate them. That's something else I would like to look at in the future is, can we get a place in these infusion centers for someone from our team that can meet with these patients, see them face to face, and explain these programs. With such a widespread system, that's hard. We have hospitals that are 5-6 hours apart from one another. So finding employees that we can have at those different facilities would be the challenge there. But it would be ideal. In the interim, we just try to work very closely with the folks that are on site, mainly the social workers or financial counselors, to explain the programs and make sure that they know what's going on. Usually when I come to conferences like this too, and I find the different resources like the Pink Fund that was mentioned earlier, or various programs that help with other resources outside of medications, I always take that back to the financial counselors and social workers and share that with them, so that when they do get that information from a patient or a nurse that, hey, this person could really need some help with this or that they have the same resources that we do.
So in your setting, you have a financial counselor and social worker, and they
Yes.
might both be dabbling in
Yes.
doing copay assistance or.
Yep. That's really one of the biggest challenges. So we have social workers that fall under nurse management. We have pharmacy that falls under pharmacy management. And then we have financial counselors that fall under the revenue cycle and patient finance team management. So we're all under 3 different teams, and we're really trying to coordinate those efforts and try to get it under one bucket. I think
or diagnosis phase.
we do. Yes. Yeah. That's one of the first things that they look at as well, whenever they're investigating programs. And a lot of it is just an online search right now until we find the best software to really optimize that. Yes.
Do you monitor, or do you have someone monitor when the patient no longer needs to be on the free drug program? As in, of course, when the authorization is denied, they need to be on the free drug program as long as they're on the drug. But as far as meeting their out of pocket, do you have anybody that works on that to transition them off of that so that revenue is coming in once it's available?
Yeah, that's a great question. So we don't have anybody actively monitoring that, but we do whenever we go for re-enrollment and we identify that the patient maybe has gotten a different insurance or they no longer qualify, that their not re-enrolling. But we have found instances where the patient has gotten an insurance a couple months prior, and we've been getting this free drug for them, and we were never notified that their insurance situation changed. So there's definitely room for improvement there, and we definitely need to figure out a way to more proactively monitor those changes. And we're hoping, I know Mike mentioned early the Epic financial assistance module. We're hoping that there might be something within that module that can assist with that as well. Did I see another hand? Yes.
Get foundation assistance for drug numbers. That's
So we do. So our specialty pharmacy is a little bit separate from our enterprise pharmacy. They're technically a different company, even though they're within our health system. So they have their own patient assistance and authorization team. So they do a lot of that on their own, but they do work very closely with us if they identify a patient that they're not able to help, for us to look into additional opportunities. And as a part of our consolidated services center, we're really hoping to bring together our specialty pharmacy team and our enterprise team at least into one room. Maybe they're not going to report to the same people and it's going to be kind of a dotted line type structure. But if we can get them all together working out of the same cubicle space or area, then they can communicate a lot better with one another and we can streamline processes between the two.
We had a slide on a little of your slides about white bag resolution.
Yes.
Is that a pretty large issue for your practice? Is it predominant? Is there certain payers that you see that's happening with? And how successful is your pushback saying we don't allow third-party drug to come into our healthcare system or infusion? And the argument to do clear bagging, we're able to build maybe the pharmacy benefit, the medical benefit in that situation.
Yeah, so with the white bagging, we have seen a pretty large uptick in that. I would say Cigna and United Health were probably our two biggest. We had our payer relations team work with United, and we were able to negotiate some terms to where we were able to get our internal specialty pharmacy within their network. So that was very valuable. We have not been as successful with Cigna. So we have been just pushing back and telling them, we don't allow this. It is a policy within our organization that we don't allow white bagging. Of course, we're not going to affect patient care negatively. So if the patient needs it, we're going to take care of them. And we do have a piece within that policy that allows for exceptions and working with the pharmacy team to allow that. Another thing that has been great for us in West Virginia is that going into 2023, our legislation is going to go to vote on a law to forbid that within the state of West Virginia, and to allow, or for payers to allow patients to go to whatever specialty pharmacy they would like to and not have those exclusions. So as we've talked with payers that have forced to an external specialty pharmacy, we've let them know that that is coming up and that it's very likely it's going to be passed in addition to our health system policy. And 9 times out of 10, they overturn it and allow us to either do the medical benefit or allow our internal specialty pharmacy to fill.
One follow-up to that. Have you seen in your area region some insurance payers have a site of care provision whereby if the treatment is going to be an outpatient hospital setting, which they deem is a much more expensive place for the patient to receive treatment, or should you send it to a freestanding infusion center or a private practice? Have you seen that in your territory too? What's your solution in those situations?
The biggest thing we've seen is them pushing to home infusion. Yes. Yeah.
Supportive care.
Supportive, yes.
Okay.
Yeah, so that's really the biggest thing we've seen as far as site of care, pushing to that home infusion. And we do have a home health service within our health system as well. So we push to get them to utilize that home health service. Yep. Any other questions?
So when it comes to site of care,
Yes.
you mentioned you have your specialty.
Yes.
Was that one of the reasons? Did the specialty pharmacy already exist prior to site of care, or did you develop?
The specialty pharmacy existed prior to the site of care issues. Yeah. Yeah, our specialty pharmacy has been around for want to say 6 to 7 years roughly. And the site of care issues have really just started coming over the last year or two. Any other questions? All right. Well, thank you guys. We'll also be having a financial navigation panel at the end of
So it sounds like you guys can go early to lunch. Where is
Lunch should be right here in the hallway. I think there may just be setting up right now. It wasn't there when I walked in. But it'll be right here. You won't miss it.
Well, yeah, we're